it started to blur out really bad. But this is the trauma protocol. Tripp has it already. Dr. Winslow at the state office has it. We've already been through this and got it all approved before, so this is just a cursory piece that we had to go through. And it looks exactly the same like the one that the med board's already approved previously. What you'll notice is down on the far right-hand side for hemorrhagic shock is where you will give blood. You'll give 1 unit to an adult. Okay? You'll just give a whole unit. And with the goal of getting the systolic blood pressure to at least 90, okay, or 100. And at that point, once we hit the 100, we'll shut it down. If the patient doesn't get up to 100, then we'll just infuse the entire unit. So if you get to the hospital and the blood is still infusing, the ED staff knows, and we're going to continue to train with them. We've done a couple already, but they know that we're going to finish up our unit, we're going to disconnect our tubing, and we're going to step back and walk away. We're going to grab our toys and we're going to leave. All right, when we say trauma red blood, they're going to preset their Belmont device, their mass transfuser, and they're going to have it primed and ready to go. We're going to disconnect our tubing completely. They're going to connect theirs on and go. There will not be any interactions of the systems. If we haven't finished that unit, we'll go ahead and finish that unit and then disconnect, and then they can reconnect if they decide that the patient needs more additional blood on top of that. The PEDS dose is 15 per kilo for like 2 to 18, and then anything less than 2, you just have to call a PIC, but it'll be there in the protocol. We talked about this. So why are we not going with this whole multiple different steps? We put this in place. San Antonio pioneered this. We put this in place in Jacksonville, and it was too cumbersome. This needs to be high speed. Okay, this patient is literally dying right in front of us. And so we don't need to start going down the list and trying to figure out if they meet one of these criteria or 2 of these criteria. What happens if it says that it has to be lower than 70 systolic? What if it's 72? Can we still give it? No. It became too cumbersome, and so we got rid of all of it and said paramedic discretion, hemorrhagic shock index greater than 1. So as long as the heart rate's greater than the blood pressure, then you can give it. And like Dr. Pettini said, the one caveat is beta blocker. That's why we have paramedic discretion. So if you have a guy who's trapped in the vehicle, he's unresponsive or altered and doesn't know his med list, paramedic discretion. If you guys think that he's bleeding internally and his blood pressure is terrible, give it. Okay? You don't have to go through 7 different steps to try to figure out whether or not this patient needs blood. We don't have time for that. Okay? So it's shock index greater than 1. You believe they're in hemorrhagic shock, paramedic discretion. And so there's shock index for you. Really simple. I think Dr. Pettini hit on it. What about transfusion reactions? Had a couple people ask me about that. The 2 biggest transfusion reactions we would theoretically be concerned about is taco and trolley. Go ahead and prove it. That a patient has pulmonary edema or the patient had a lung injury was related back to us getting that single unit of blood and there was some type of reaction to it. They've done the math. San Antonio did all this because people way smarter than I am. Did it, and you have to give, theoretically, before you're going to encounter a reaction patient who's going to full-blown react to it, is like after 300 uses of blood before you'll encounter your first patient. So it's extremely safe. I can't imagine how many units of whole blood have been given across the United States with all the systems that are participating. And as far as I know, there's not a single report yet that exists where they've connected it back.
So we see taco and trolley has a little later reaction on patients that don't receive whole blood. So taco is transfusion-associated circulatory overload. So sometimes you can, especially with a Belmont rapid infuser and you're in the OR, you have to give a lot of fluid, but some people just won't handle the blood and they'll get circulatory overload. That's manageable. The transfusion-related lung reaction, you can salvage people through that. And again, it tends to be more with the volume of blood that's been given.
And it's a late thing. In our world, it's a very late thing. So really not a risk, and definitely not a significant risk enough for us to be concerned from our perspective of what we're going to use. Dr. Pettini hit again, males and females. So our goal is, and with our blood donation center, we've already started working on, we're not going to call it Brothers in Arms, we're going to try to find something else that's catchy to utilize, but we're going to focus on male low titer as a donor and target those population groups. We already collect whole blood every day, all day, and so this is not really that big a deal. We titer, our blood bank can titer in-house, so we have all the components in-house, and we'll cycle blood back in after a 14-day rotation period. If you use it, you'll just go down to blood bank and check out another unit, and we'll actually write down the process for doing that. But this is a life or death issue, so we're really not terribly concerned. And like Dr. Pettini talked about, that RH factor is something that we'll address down the road with the hospital. So, like I said before, to me, I've seen this firsthand. I've seen patients go from unresponsive or altered, ashen, and gray. I've seen them with 40/0 blood pressures that are exsanguinating. Internal pelvic injuries, gunshot wounds, motor vehicle collisions, ejections, all these different type of things, and they literally come back to life. I've had patients unresponsive that have woke up after we've given them a unit of whole blood and watched their blood pressure go. One lady I can think of, an autopedestrian, busted pelvis. She went from 40/0 to a 100 blood pressure, and then came back to visit us. Pretty amazing stuff. So, this has been our Achilles heel forever and ever and ever. We've never really been able to do anything for significant trauma, nothing of any substance. And this is in concert with making sure that they're warm, using tourniquets and stopping the hemorrhage, giving them back the volume that they're missing. And probably the best analogy I've ever heard of and why we're going to use whole blood is a trauma surgeon in Jacksonville. He's big, he's 6'4", he played offensive line at the University of Florida. And the analogy he uses, and he participated in the San Antonio program, wrote a lot of papers. He talks about it like a football team. You can take all the best players on a football, all the all-stars in the NFL, and you can put them all on the same team. And they'll probably win a few games. They're probably pretty good independently that they'll win a few games. But when you take a team that has played together their entire life and can anticipate each other, they can probably beat that group of all-stars. And that's what we have. Instead of 1-to-1-to-1, where we may have upwards of like 12 or 15 different people who've contributed to that 1-to-1 collection, they're all individual all-stars, but they've never played together. This one unit of whole blood is one football team that its entire life has played together. And so all the components are there. Everything that a person needs is going to be there. So hugely impactful.
Shock index, is that for adults and peds?
Yes.
Okay, so what about the 2, 3, 4-year-old whose normal heart rate is expected to be higher than their blood pressure?
Yeah, that's a great point. I didn't think about
I don't know what the age cutoff. We just use it in adults, but I'm not sure.
Yeah.
Because I was just thinking of like my 4-year-old, and his heart rate would naturally be higher than his blood pressure. So.
We have the number of kids that we've had. We've always fallen back on paramedic discretion. Paramedics typically with kids are a lot more conservative than they are with adults, and so the decision process has always been the ones that we have given blood to. Every kid I can think of that we gave it to were like horrendous, like their guts were hanging out, like a 3-year-old. So we really never really looked that hard at it, but that's a really good point. I'd probably fall back on the paramedic discretion component of it. That's a good question to ask CJ. We'll send a message out to San Antonio to CJ Winkler and see what they say, and Dr. Jenkins and Stewart. Yeah. That's, and like I said, we're always just by bias more conservative with kids. We're not usually willing to go super aggressive. So that's a really good point I've not really contemplated or thought about, because kids have always been such a small part of the population.
Yeah, the youngest we've had is 16 years old. We haven't had anybody, and definitely these 16-year-olds were adult body size. So
Yeah.
And I'll tell you, just because we wrote in here that you don't have to call, doesn't mean that we're telling you can't. So if you have an adult and you're not sure and you want to call the PIC, knock yourself out. Before you give it, go for it. There's nothing wrong with doing that, but there's no requirement unless they're less than the age of 2 that you have to.
You define for this purpose peds as 2 to 18?
Yes.
16?
Yes.
So the 16-year-old GSW victim gets the 15 milliliters per kilo dose?
Yep.
And anybody in that 2 to 18 is on bronchial PIC?
Yep. All right. Good questions. Those are great questions. Never thought. I don't know why that never crossed my mind.
Well, I have a 4-year-old.
As soon as you
so
said it,
that's
I was
why.
like,
Yeah.
As soon as you said it, I thought about it, and I'm like, damn, I can't believe we never.
I was thinking the same thing. I should have that like right on my mind, but I don't. We don't use shock index as part of our parameters, and we're only adult. I mean, we get peds in our place, but we have Connecticut Children's Hospital, and some of our medics have asked if they do get a pediatric patient, should they just call medical control, and we give the same answers. Absolutely, that's what we do. So, yeah.
That's what I...
Yeah.
I think
It's an interesting. What? Sorry.
she was asking the age-based question, because we've typically always done it if they're 12 years old or 14 years old, they don't fit the Brazos, it's considered an adult.
Well, I
Yeah,
guess
so-
it's only 100 pounds, 30 or 100 pounds is the full bag.
Right, so you just want to make
Not
sure
weight
that's...
base.
Yeah, the rest of our pediatric protocols say if they're longer than the base tape, then they're treated as adults.
You'll wind up giving the majority of it anyway.
Yeah, I think that's what we ended up doing with ours. If they were 40 kilos or over, they got the whole bag, and then we do weight base below that, 20 mLs per kilo. So it's a little higher than what yours is.
And we tried to follow KISS method. We tried to make it as stupid simple as possible, just because of the fact that in this situation, these are high speed moments, and they need to be, we need to be doing as much cognitive offloading as possible. So if you're having to do some kind of weight-based dosing and guessing, we want to try to minimize that to the best of our abilities. But
We'll
15,
add that to hand heavy also.
yeah, 15 per kilo is a pretty easy one to do.
Yeah, he's a good one. Do you know Peter Antevi? Because
Yes.
okay. I would field that question to him because
He's got blood.
They've got blood, so yeah,
He's got blood.
that would be a good question.
We'll call him up.
So we actually did have our first patient this summer who was 15. He was our youngest, not 16. I was mistaken, but they took him to the pediatric trauma center, and it's the first patient since our blood program started that went to the pediatric trauma center. So although they were aware of it, in a little over a year, we never brought a patient there. So then when they came in the door, they were just like shocked because they had never received a patient other than the hems flying in with blood, on a ground ambulance, and it kind of shocked them when they called in. It was an entrapped 15-year-old in a pretty bad car accident with the blood loss was in the femur, and he was really shocky. And it went a long ways, and they actually called us to say, they were just amazed that this patient had received blood and was doing well. So
there's not super tight controls on dosing. So if you're off by 50 mils or 100 mils, okay, then you get the blood. That's what we're interested in. So if you have a 16-year-old and you treat them like an adult, then we're gonna pat you on the back, not cut your head off.
I guess one other thing, David, we mentioned yesterday, but you can potentially run into a patient that has a religious objection to receiving blood products, Jehovah's Witness, and you actually may have providers in your system that have that same religious orientation. You have to be sensitive to that, to the providers in your system, as well as the patients. So what we basically do is we have our medics just say, if they're at all competent to say, we're going to give you human blood to save your life. We really feel you need this. And if there's an objection from the family or somebody else, that's the trigger for it. So we don't have them signing. That's about the best I think we can get. And CJ in San Antonio, they crossed that early on, and they actually had a couple of paramedic firefighters that were very against it. That they rotated into other areas that they wouldn't be around the blood program. But it was an unintended, nobody thought of this ahead of time type of thing. So we've only had one patient refuse blood, and it wasn't because of the blood. It's just that he had bled out of a dialysis catheter. It was very shocky, but he had no access, and they were going to have to put an IO, and he was opposed to the IO. He did not want the IO.
Yeah, we had the religious contraindication built in, but we've never encountered anybody object to it. And if they're unconscious, they don't have the ability. So everybody that's unconscious gets it.
Yep.
Yeah. It's an important thing if they're conscious to ask that question. So don't want to violate religious practice. Any other questions?
Each QRV is going to carry a warmer with blood.
Yes, and so let's break for 10, and then we'll introduce a different. I know you guys have QuinFlow. We're going to introduce you to something different. What we're going to use on the ground, and then maybe just maybe we'll see. Go ahead and take 10.